Professor Cesare Gridelli, you're discussing here at the Lugano meeting, the European Conference in Thoracic Oncology, maintenance therapy and specifically the use of targeted therapies. You're also looking at first-line therapy in EGFR mutated patients with lung cancer, non-small cell lung cancer. First of all, tell me, what is the big progress in this area, discussing maintenance, first of all?
Yes, the maintenance is an interesting new approach where we know that if we stop the treatment of patients after chemo, after 6 cycles of chemotherapy, we know that the patient will progress. And the idea is to administer a maintenance treatment with in this case with a target therapy with a different drug. The name is switch maintenance treatment, when we use a drug that is not administered in the first part of the chemo program. And we know that we have some interesting trial. The main trial is the Saturn trial that showed a superiority advantage for when we give erlotinib is target maintenance treatment after chemo as compared to only observation.
Right, now you've got a lot of choices here because you could give chemotherapy with standard drugs, or you could give a molecular drug. And if you do give a molecular drug, you need to decide which one. How do you make those choices?
Yes, for patients that have a particular mutation, that is a genetic alteration, mutation EGFR, epithelial growth factor receptor, we have evidence that some kind of drugs, EGFR inhibitors, small molecule, mainly gefitinib or erlotinib, we have a very high response rate, progression-free survival, better result as compared to chemotherapy. The question is, but we could use chemotherapy as first approach, and then we could use this kind of drug subsequently after when failed the chemotherapy. But we know that when we have some comparative randomized trial, when we use first target therapy, EGFR inhibitor as first treatment approach, we have a greater advantage, superiority as compared to chemo in terms of regression, response rate, progression-free survival, quality of life, and toxicity profile.
So if you had already used a small molecule TKI in your first-line therapy, then that implies you should continue to use the same small molecule as maintenance?
Yes, until the patients progress. Clearly, but when the drug works, we continue to use until that the patient then progress disease progression, and then we can change and administer then chemotherapy.
Now, this is among patients with advanced non-small cell lung cancer. You discussed erlotinib and gefitinib. How do you make the choice between those two small molecule agents?
To date, we have that gefitinib is the first drug approved from European Authority Agency, EMEA. And now we have some, but the drug is similar. Very interesting drug with erlotinib. Probably in the next month we will approve two erlotinib, but probably with two similar drug, and I think that both efficacies in this kind of disease.
If you are targeting the epidermal growth factor receptor, then you could also presumably go with cetuximab, a monoclonal antibody.
Yes, it's a different approach. It's not small molecule, but monoclonal antibody, and it's a different mechanism of action. But today the drug is not approved yet because there is some problems from the regulatory agency. But probably this is a renewed interest because analyzing the data of clinical trial, they showed that when we can use immunohistochemistry EGFR expression, high expression, the drug works better.
So if you have an EGFR receptor mutation, you can go initially with a small molecule, quite possibly with a monoclonal directed to EGFR, and you continue with maintenance probably too.
Yes, but the problem is that today the monoclonal antibody is not related in terms of efficacy with EGFR mutation, but is a matter only for small molecules, gefitinib and erlotinib. But monoclonal antibody, cetuximab, works better not in EGFR mutation, but high score of positivity immunohistochemistry EGFR expression.
Now, is there a case for looking also at vascular endothelial growth factor, and does that have implications for therapy?
Yeah, angiogenesis is one of the main mechanisms through the tumors grow and proliferate and metastasize. So we need to target angiogenesis, the new angiogenesis of tumor grow. And in this case, we have the only drug, we have several drugs investigated in the years, and now we are under investigation other drugs. But today, the problem, the only approved is bevacizumab, that is a target, is a monoclonal antibody that targets particularly VEGF, and it showed to improve survival when combined to chemotherapy as compared to chemotherapy alone.
Now, does the same thing apply there, that if bevacizumab worked in first-line therapy, you would continue with that molecular agent in maintenance?
Yes, it could be a proposal. We know that there is a trial that showed that when you use bevacizumab combined to chemotherapy as first-line approach, then you can even maintenance with erlotinib, with a different continuing bevacizumab and adding erlotinib. We have better results as compared to bevacizumab alone as maintenance treatment.
There is an assumption that molecular therapies have lower toxicity in the maintenance role as compared with chemotherapy, but are there patients who would be better off on chemotherapy for maintenance?
But I think that we have, today we can use erlotinib that is a better tolerated. The problem is a better tolerated as compared than we use the same drug in second, third line setting, probably because the patient is a better clinical condition, and we have very low toxicity profile with erlotinib maintenance. But we have also pemetrexed, that is a chemotherapy agent that now is used as a maintenance treatment as a chemo, and other investigation in different settings. It is with a very low toxicity profile.
Let me ask you though about which patients you can have maintenance therapy on. Do they need to have disease fully controlled, or can it be just stable disease?
Yes, we know that the better results were being obtained when the patients achieve a stable disease after chemotherapy as compared to patient that responds to chemo. So we have analyzed some kinds of factors. The most important in the stable disease, we know that maintenance with erlotinib and even with the pemetrexed works better. This is the first point.
So could you sum up what you've been able to learn about the use of maintenance? Because it still isn't obvious that maintenance will be beneficial, yeah. or is it now?
Yes, the problem that we have, we know that we have a small advantage as compared with the non-maintenance. But the problem, we know that history of cancer treatment is based on this small improvement, piece by piece, and we saw probably is another piece of evidence that and another strategy we have to optimize our treatment.
Nevertheless, even the molecular therapies do have toxicities. Some of them may not be life-threatening, but they could cause a reduction of quality of life. What's your advice there to doctors?
No, but the problem that our clinical trial for the Saturn trial that use erlotinib as maintenance showed that there is no any kind of reduce of quality of life as compared to non-maintenance. So we have the better results in terms of quality of life, even so for use of analgesics and on pain. We have no deteriorating quality of life, but improved quality of life giving erlotinib as maintenance.
So from what you're saying, all molecular therapies are not equal?
Yes, not all are equal in terms of toxicity profile, you mean? Yes, yes, it's a different toxicity profile. For example, we have the gefitinib is a less toxic in terms of skin rash, skin toxicity, diarrhea as compared to erlotinib, but we know that erlotinib is a better tolerated in terms of liver toxicity. We have for different drugs, different toxicity.
So what's the bottom line coming out of this conference here in Lugano, in your opinion, about the use of maintenance therapy in advanced non-small cell lung cancer?
I think that at the end of the day, the message that maintenance treatment is a new approach that gives small but significant improvements in terms of survival for our patients. The criticism is that we have a small advantage, but as I said before, we know that history is a step-by-step improvement in the results.
Cesare, it's been a pleasure talking with you here on eCancer TV, and we'll listen and look out with great interest for further developments.
Okay, thank you very much.